Okay, welcome back, guys, and let's continue on USMLE Step 1 Rapid Review podcast. If you are new here, please check out usmlestrike.com website and check out the USMLE Step 1 Mastery course. Okay, let's get started. What's the name of the drug which is prostaglandin E1 analog, which can be used to promote uterine contraction, and it can be also used with NSAIDs for gastric protection? What is the name of the drug? Misoprostol. So, since it promotes the contraction of the uterus, it can be used to facilitate labor or terminate the pregnancy. Let's talk about G protein coupled receptors. Now, these G protein coupled receptors are actually 7 pass receptors, so that would have some extracellular domain, transmembrane domain, and as well as intracellular domain. Now, extracellular domain would bind with a ligand, and that transmembrane domain of that G protein coupled receptor would pass that membrane 7 times. That's why they are also called a serpentine receptor, and it would have an intracellular domain. Depending on what type of G protein is linked to that receptor, they have certain names, like for example GQ, GS, or GI coupled receptors. Now let's say norepinephrine binds to the alpha 1 receptors of the smooth muscles, and that alpha 1 receptors are actually linked to the GQ protein. So what happens exactly when the norepinephrine binds to the alpha 1 receptors? So norepinephrine would bind to the extracellular domain or the ligand binding domain of that protein, and then it will give an intracellular signal to the G protein itself. Now G protein is a trimeric protein that would have alpha, beta, and gamma component. Now alpha component, once it's bind to GTP, the beta and gamma component would dissociate, and now that alpha component, which is energized or that has GTP, is going to activate an enzyme. What is the name of that enzyme? That's phospholipase C. So far we talked about norepinephrine binding to alpha 1 receptor, that's G protein coupled receptor, especially GQ protein, and then alpha unit of that G protein is going to bind with GTP, and now beta and gamma will dissociate, and then alpha unit, which is now energized with GTP, will activate phospholipase C. Now what will phospholipase C do? It will split phosphatidyl inositol diphosphate into two parts. So what are they? Diacylglycerol as well as inositol triphosphate, so DAG and IP3. Now usually step 1 would really focus on what these proteins would do. So what does IP3 do? It will stimulate endoplasmic reticulum to release calcium from endoplasmic reticulum into the cytoplasm. So IP3 and Ca plus 2, so both have some numbers in them, so that's how I remember IP3 and Ca2. And diacylglycerol that has 3 letters is going to activate someone with 3 letters, that's protein kinase C. Okay, so IP3 stimulates calcium from endoplasmic reticulum. Diacylglycerol would stimulate calcium release with the help of protein kinase C, and ultimately more calcium will lead to smooth muscle contraction. So the bottom line which I want you to remember is the G protein coupled receptor, especially GQ. What's the first step in activation? It's the alpha unit of the G protein is going to be energized with GTP. Now this is true for even GS protein, where you have the alpha unit which is energized with GTP, and eventually it will activate adenylyl cyclase, which will convert ATP into cyclic AMP. And similarly, the alpha unit which is energized with GTP of the GQ receptor, it's going to stimulate phospholipase C, which is going to split phosphatidyl inositol diphosphate into diacylglycerol and inositol triphosphate. And then so how does GS protein would work? Let's say for example epinephrine binds to the G protein coupled receptor, and let's say GS is stimulated. Again the same story, GTP would bind with alpha receptor, and that activated alpha receptor is going to stimulate what enzyme? Adenylyl cyclase, that will convert what into what? ATP into cyclic AMP. Cyclic AMP is going to activate what? Protein kinase A, and ultimately that protein kinase A would have physiological actions by phosphorylation targets. Now once you have ATP converted into cyclic AMP with the help of enzyme adenylyl cyclase, what happens to cyclic AMP if it's not used? It should be degraded, right? What's the enzyme which will degrade cyclic AMP into 5-AMP? Phosphodiesterase. So if you give phosphodiesterase inhibitors, like for example methylxanthines, caffeine, the levels of cyclic AMP would go up and it will give subsequent physiologic actions. How do the peptide hormone receptor differs from the receptor which are bound by steroids and, let's say, for example, thyroid hormones? So peptide hormones, like for example epinephrine, ACTH, they bind to extracellular receptor, whereas steroid and thyroid hormones binds to cytosolic or nuclear receptors. And of course, if we are talking in terms of time, how does peptide hormone differ from steroid hormones? Peptide hormones are relatively quickly acting. They act in minutes, and steroid hormones usually act very slow and it takes hours. Where is HCG secreted from? The placenta, right? And exactly syncytial trophoblast of the placenta. Now this HCG is structurally related to TSH, FSH and LH, right? So what can happen when you have very high levels of HCG? Like for example, let's say you have choriocarcinoma, very high levels of HCG. Can you get hyperthyroidism because of that? Yes, because HCG is structurally related to TSH, right? And sometimes very high levels of HCG in pregnancy can cause gestational hyperthyroidism. Now, since it's related to FSH and LH, it also has a therapeutic advantage. Like for example, in assisted reproductive technologies, you can give HCG to stimulate the ovarian growth. That's with the help of FSH, and it can also induce ovulation. So HCG can induce LH surge and ultimately ovulation. So it can help in assisted reproductive technologies. The next one is, why would you see hyperpigmentation in Addison's disease or primary adrenal insufficiency? Now in primary adrenal insufficiency, you have low levels of what? Cortisols, right? So low levels of cortisol will give a feedback. So what will be the levels of ACTH? High ACTH, right? Now where is ACTH produced from? There's a precursor called as POMC, which is also called as pro-opiomelanocortin. So very high levels of POMC can actually ultimately help in production of ACTH, and in addition to that, you can also produce MSH, that's melanocyte stimulating hormone, along with beta endorphin. So that's why in Addison's disease, when you have low cortisol, high ACTH is actually made from POMC, and high POMC will increase the levels of melanocyte stimulating hormone. So that's why you classically see that hyperpigmentation in primary adrenal insufficiency. What factor would decrease the release of growth hormone? Somatostatin, right? Like for example, can you name some synthetic analogs of somatostatin? Octreotide. Now the octreotide can be used to manage conditions like acromegaly and some of the neuroendocrine tumors because it's helping in decreasing the synthesis of these hormones. What is the embryological origin of anterior pituitary? It's oral ectoderm and specifically Rathke's pouch. Now sometimes this remnant of Rathke's pouch can lead to a tumor. What is that tumor called as? Craniopharyngioma. Now what is the embryological origin of posterior pituitary? That's neuroectoderm. So usually the hormones are actually stored in posterior pituitary. They are not produced in the posterior pituitary. They are actually produced in hypothalamus, like hormones like oxytocin and ADH. They are produced in hypothalamus and stored in posterior pituitary. So again, posterior pituitary is derived from neuroectoderm, anterior pituitary derived from oral ectoderm, specifically from Rathke's pouch. What is the embryological origin of pia mater, arachnoid mater, Schwann cell, chromaffin cells, and peripheral nervous system neurons? Neural crest cells, very, very important. And what are some of the other embryological origin which are derived from neural tube? You can get astrocytes, oligodendrocytes, ependymal cells, spinal cord, as well as CNS neurons. So usually the supporting cells of the CNS, like for example astrocytes, oligodendrocytes, ependymal cells, they are derived from neural tube except microglia, which is derived from mesoderm. Where is prolactin secreted from? Anterior pituitary. Who stimulates prolactin secretion? So there is a substance from hypothalamus called as thyrotropin releasing hormone that actually stimulates anterior pituitary to release prolactin. But usually prolactin is also inhibited. And why is that? Because hypothalamus produces dopamine and dopamine actually inhibits the secretion of prolactin. So if there is any condition where you inhibit the release of dopamine, you'll have high levels of prolactin. Like for example, if you give any drugs which decreases the production of dopamine, that will actually increase prolactin production. Like for example, antipsychotics blocks dopamine, that will result in elevated production of prolactin and may result in galactoria. Now also this elevated level of prolactin will actually decrease synthesis of GnRH. So ultimately less GnRH, less FSH and LH, and ultimately you'll have decreased ovulation and spermatogenesis. So in females, when you give antipsychotics, that can result in elevation in prolactin, that will lead to galactoria, and this elevated prolactin will also inhibit GnRH, leading to amenorrhea. So elevated levels of prolactin ultimately leads to galactoria and amenorrhea. And same happens in prolactinoma. If you have elevated levels of prolactin, ultimately you'll have galactoria amenorrhea syndrome. Now, since you know if you block dopamine, prolactin levels will be high. What if you give some of the dopamine agonist? Can you name some dopamine agonist? Like cabergoline and bromocriptine, right? So if you give dopamine agonist, that will actually decrease the synthesis of prolactin. So they are one of the first drugs you can give to the patients who have prolactinoma. And usually what is preferred more, cabergoline or bromocriptine? Cabergoline is usually preferred over bromocriptine due to its efficacy and side effect profiles. Okay, now where is ADH secreted from? Posterior pituitary. What's the other name of ADH? Vasopressin. Now ADH can act on the principal cells of the DCT, right? In the late distal convoluted tubule and the collecting duct. So ADH can act on, let's say, DCT and collecting duct via what receptors? It's usually V1 or V2 receptors. It's V2 receptor. So ADH will bind to the V2 receptor and it will activate what G protein coupled receptor? It will activate GS, right? So ADH binds to the V2 receptor, activates GS protein, and ultimately you'll have again alpha subunit which will be charged with GTP, and that will activate what? Adenylyl cyclase, that will convert ATP into cyclic AMP. Cyclic AMP will stimulate protein kinase A. Remember, cyclic AMP, protein kinase A. Now this protein kinase A will phosphorylate aquaporins, and ultimately you'll have insertion of aquaporins channels in the apical membrane of the collecting duct, and it will reabsorb water. So ADH works on V2 receptor, which will ultimately help in absorption of water only. Remember, it's only water absorption, in contrast to aldosterone, which actually absorbs both water and sodium. So ADH can also act on blood vessels. And how does it act? So ADH can act on blood vessels with the help of V1 receptors. So via V1 receptor, that's again, it's coupled with what? It's GQ protein. Remember, V2 is GS protein, V1 is GQ protein. So ADH would bind to the blood vessels with the help of V1 receptor. Ultimately GQ will be activated, and GQ, again alpha unit charged with GTP, will activate what enzyme? Phospholipase C. Now that phospholipase C will convert inositol, phosphatidylinositol biphosphate into two parts, inositol triphosphate and diacylglycerol. What's the action of inositol triphosphate? It will trigger the release of calcium from endoplasmic reticulum, and this calcium will lead to smooth muscle contraction. So ADH has two actions, vasoconstriction and water retention. Now what if your posterior pituitary does not have the ability to secrete ADH? What is that called as? That's central diabetes insipidus. Will it respond to exogenous ADH? Answer is absolutely yes. Now, if you are damaging posterior pituitary, will it result in permanent central diabetes insipidus or transient? So damaging posterior pituitary will typically result in transient central diabetes insipidus, as your hypothalamic nuclei are still intact, and ultimately, axonal regeneration and hypertrophy can adequately allow ADH release into circulation. Whereas what can lead to permanent central diabetes insipidus? If you damage directly the hypothalamic nuclei, so you are not producing ADH itself, which will lead to permanent central diabetes insipidus. Now this central diabetes insipidus has been renamed to arginine vasopressin deficiency. That's AVPD, arginine vasopressin deficiency. Now if you have central diabetes insipidus, what will be the levels of sodium in your blood? So think in this way, you do not have ADH in the system. You are not able to absorb free water. So all the free water is sent into the urine. So you'll ultimately have hemoconcentration. So your serum sodium concentration will go high, whereas your urine will be very, very dilute. So your serum osmolality will be very, very high and your urine osmolality will be very, very low. That's a classic scenario of central diabetes insipidus. And the treatment is giving exogenous ADH. Now, what is that condition when you have mutation in the ADH receptors that's in the collecting duct, or where there's a defect in GS protein, or there's a defect in adenylate cyclase in the last part of the nephron? That will result in what? Nephrogenic diabetes insipidus. That means your hypothalamus pituitary is okay. That means you are producing ADH, you are secreting ADH, but your levels of ADH are adequate, but it's not able to act on the last part of the nephron. So that's ADH resistance. That's classically nephrogenic diabetes insipidus. Now, this is again renamed to arginine vasopressin resistance. So the two new terms are now arginine vasopressin deficiency, which is central diabetes insipidus, and arginine vasopressin resistance, which is nephrogenic diabetes insipidus. Now you can have a third entity where everything is normal, but you still have high levels of ADH, but those high levels of ADH are not produced from the hypothalamus or posterior pituitary. They are inappropriately produced. Like for example, if you have small cell lung carcinoma, you can exogenously produce, or you have autonomous production site of ADH. So that's inappropriate production of ADH. It's also called as syndrome of inappropriate production of ADH or SIADH. See, when you are dehydrated, you have appropriate production of ADH. That's appropriate, right? When you have dehydrated, you want vasoconstriction and water retention. But when it's not needed and still you have high levels of ADH, that's inappropriate or SIADH. What do you think will be your serum osmolality in SIADH? It will be low because you have high ADH, high water retention, so low serum osmolality. And what will be your urine osmolality? It will be very high, right? So low serum osmolality and high urine osmolality is classic of SIADH. Now, when you have a lot of water in your blood, what will be the concentration of sodium? That is low, so you'll have hyponatremia, and usually these patients are euvolemic. So SIADH is usually euvolemic hyponatremia. And what's the ultimate treatment of SIADH? The answer is fluid restriction, or you can also use some of the medications like conivaptan or tolvaptan, or you can just destroy the last part of the nephron with the help of demiclocycline. So what's the mechanism of conivaptan or tolvaptan? They are actually vasopressin receptor antagonist. So you have ADH, but you are not allowing that ADH to work on the V2 receptor, or you just damage the last part of the nephron. So there'll be no ADH receptors left that you can do with demiclocycline. So three primary therapy for SIADH: fluid restriction, you can use ADH antagonist, or you can destroy the last part of the nephron. What's your diagnosis if you see a newborn who has pot belly, puffy face, he's pale, and he has severe intellectual disability, and umbilicus is protruded, tongue is protuberant? What's your diagnosis? That's congenital hypothyroidism, right? That will result in severely stunted physical and, of course, retarded mental growth. And of course, the leading cause of congenital hypothyroidism is thyroid dysgenesis. That's very, very high yield. Now, this congenital hypothyroidism was historically called as cretinism. And there's a famous mnemonic PPP, but, B-U-T. So pot belly, puffy face, pale, and butt is brain, that's poor development, umbilicus, that's protruded, and tongue, that is protuberant. So PPP, but. Okay, now let's look at the thyroid hormone synthesis. So first of all, you'll have iodide, right? That's I minus. Now I minus is actually transported into the follicular cell with the help of what? Sodium iodide symporter. That's an active transport because you have very high levels of iodine concentration in your thyroid as compared to the blood, right? So it has to be actively transported into the thyroid cells. So first of all is iodine or iodide uptake. So iodide is actively transported into the follicular cell with the help of NIS. What is that? Sodium iodide symporter. Now once the iodide is in the follicular cell, that is oxidized to iodine. So iodide, that's I minus, is oxidized to iodine with the help of enzyme thyroid peroxidase. Now that thyroid peroxidase is present in the apical membrane of the follicular cell. Now, once you have iodine, now this iodine will undergo organification, right? So now this iodine is now into the colloid of the thyroid. Now this iodine will bind to the tyrosine receptors of the thyroglobulin. Now that's a protein which is actually produced in the follicular cells. Now this iodine binds to the tyrosine residues of the thyroglobulin, forming either MIT or DIT, right? Monoiodotyrosine or diiodotyrosine, depending on how many iodine binds. If one iodine binds to the tyrosine receptor, it's monoiodotyrosine. If two iodine residues binds to the tyrosine, then it's diiodotyrosine. Now, so this was the organification, right? So to sum it up, first of all, we had an uptake, sodium iodide symporter uptake, that's an active transport. Then you have oxidation of iodide into iodine. And then finally, iodine is into the colloid, thyroid colloid. Now, iodine is undergoing organification. So, one iodine binds to the tyrosine residues of the thyroglobulin, that will result in MIT. If two binds, that will result in DIT. Now, finally, we have coupling reaction. Now, if you have two DIT molecules couple, that will form T4. If you have one MIT and one DIT coupled together, that's called as T3. So this reaction of coupling is also mediated by thyroid peroxidase. So now we know three functions of thyroid peroxidase: oxidation, organification, and coupling reaction. Now there is a drug which can block thyroid peroxidase. What's that drug called as? Propylthiouracil or methimazole, right? So that can actually block the production of thyroid hormones by blocking oxidation, organification, and coupling reaction. Now there is also something which can block actually the entry of the iodide into the follicular cell. What is that? Lugol's iodine, right? When you have lot of iodine in the blood, it will not allow iodine or iodide to go into the follicular cells. Now finally, when you have, let's say, T3 and T4 after the coupling reaction in the colloid, now that protein of thyroglobulin along with T3 and T4 is now endocytosed back into the follicular cell, and now ultimately you have everything ready in the follicular cell. The next step is release, right? Proteolysis and released. Now this thyroglobulin is actually broken down by lysosomal enzyme, and ultimately it will release T3 and T4 into the bloodstream. Now who carries T3 and T4 into the bloodstream? Thyroid binding globulin. Now don't confuse TBG with TG. Thyroglobulin is a protein which is produced by follicular cell, and that's actually a scaffold protein for T3 and T4 in the colloid. Whereas once T3 and T4 are released into the blood, they actually bind with thyroid binding globulin, right? Now when you have majority of the T4, major release is T4, right? When you have a lot of T4 in the blood, it can be converted into T3 in the peripheral tissues with the help of enzyme 5-deiodinase, right? So that's how T4 is converted into T3 in the peripheral tissue. Now there are drugs which can also block 5-deiodinase, like propylthiouracil, propranolol, glucocorticoids as well as radiocontrast. Okay, final summary. First of all is the iodide uptake, which is inhibited by Lugol's iodine. The next one is oxidation, where you convert iodide into iodine with the help of enzyme thyroid peroxidase, that is blocked by propylthiouracin and methimazole. Next step is organification, where iodine binds to the tyrosine residues of thyroglobulin, making MIT and DIT. That organification is also led by enzyme thyroid peroxidase, that is inhibited by methimazole, propylthiouracil as well. And then finally you have coupling reaction, that's combining MIT-DIT or DIT-DIT. That's also mediated by an enzyme thyroid peroxidase, and then ultimately make T3 and T4. Now this is also again inhibited by propylthiouracin and methimazole. So propylthiouracin and methimazole blocks oxidation, organifications, and coupling. And finally, you have the release with the help of proteolysis and lysosomal enzymes. So you release T3 and T4 in the blood, and that actually binds to the thyroid binding globulin. And when you have T4 in the blood, that can be converted into T3 in the peripheral tissue with the help of enzyme 5-deiodinase. And that 5-deiodinase can be blocked by propranolol, propylthiouracil, and glucocorticoids. Now, if you paid attention, propylthiouracin can actually block both thyroid peroxidase enzyme as well as 5-deiodinase, whereas methimazole can actually only block thyroid peroxidase. Now, do you think when T3 and T4 are bound to thyroid binding globulin, are they active? No, only the free thyroid hormones are active. So, if the thyroid hormones are bound to TBG, that's a reservoir for circulating thyroid hormones that can be just added to the pool of free thyroid hormones. What test can be used to indirectly assess the circulating levels of thyroid binding globulin? There's a test called as T3 resin uptake. Now, if you give that radioactive T3, that will first bind to the unoccupied sites of the patient's thyroid binding globulin, and the leftovers will actually bind to the resin. So there's a clinical application to this. Let's say if the patient has hepatic failure, what will be the levels of thyroid binding globulin? It will be low. So if you do this T3 resin uptake test, what will be the uptake by resin? The uptake will be increased, right? Because you have very low levels of thyroid binding globulin, only so much of T3 will bind to the TBG and rest of it will bind to the resin. How about if you do T3 resin uptake test in pregnancy? So the resin uptake would be decreased, right? Because in pregnancy you have very high levels of TBG. If you give that radioactive T3, that will bind to all the TBG and less of that T3 will bind to the resin. So that's indirectly how they can test the levels of thyroid binding globulin. Now, when I said T4 is converted into T3 with the help of enzyme 5-iodinase, now some of that T4 can be also converted into reverse T3 or RT3. Now, usually these levels of T3 and reverse T3 are usually similar, except in euthyroid 6 syndrome, where the levels of what are high, reverse T3 or T3? Reverse T3. So levels of reverse T3 are high in euthyroid 6 syndrome, while T4 and TSH are either normal or slightly decreased. Now, previously I asked who stimulates the release of prolactin, and the answer was thyrotropin releasing hormone produced from hypothalamus, which stimulates the anterior pituitary. Who stimulates the production of TSH? The answer is again thyrotropin releasing hormone that act on thyrotropes as well as lactotropes. So TRH actually stimulates the production of both TSH and prolactin. So TRH is released from hypothalamus. It will stimulate pituitary to release TSH, and TSH will bind to the thyroid receptors, right? Now these thyroid receptors on the follicular cell, they can be also activated by other antibodies, which is also called as TRAB, right? Thyrotropin receptor antibodies, which are positive in Graves' disease. So the activation of this TRAB or thyroid stimulating immunoglobulins ultimately will result in hyperthyroidism, and this TRAB or thyrotropin receptor antibodies or TSI or thyroid stimulating immunoglobulins, they also stimulate TSH receptors on fibroblast, particularly behind the eye and the pretibial region. That's why these patients have proptosis, and they may also have pretibial edema. Now, of course, when you have thyroid stimulating immunoglobulins and you have a lot of production of thyroid hormones, T3 and T4, what will be the levels of TSH? It will be decreased. Now, again, once you have, let's say, a lot of T3 and T4, how will they act on the cell? Do they act on the surface receptor or they go inside the cell? Remember, steroids and thyroid hormone go inside the cell, right? So this T3 actually goes into the nucleus and they bind to the nuclear receptor. I think that was it for today, and if you are preparing for your USMLE Step 1, please check out USMLE Step 1 Mastery course and USMLE Strike website. And if you are also preparing for Step 2, we also have the Step 2 CK and 3 combined course, which is also in the USMLE Strike website. If you are applying for match, we also have residency match services like interview preparation, ERAS, CV editing, personal statement editing, and unlimited live WhatsApp chat support. So please check out USMLE Strike website, and thank you for listening.